Welcome to this webinar on leadership perspectives on the ASRM ESHRE IFFS joint statement on COVID-19 and human reproduction. I am Sarah Ramaya, curriculum designer at ASRM with my colleague Jessica Goldstein. Joining us are panelists Dr. Catherine Rakowski, Dr. Christina Magley, and Dr. Linda Judice, and moderator Sean Tipton. Before we begin, please note, this webinar was developed by the American Society for Reproductive Medicine, European Society of Human Reproduction and Embryology, and International Federation of Fertility Societies as an educational resource and service to its members and other practicing clinicians. While this webinar reflects the views of the panelists, it is not intended to be the only approved standard of practice or to dictate an exclusive course of treatment. Members should always use their best judgment in determining a course of action and be guided by the needs of the individual patient, available resources, and institutional or clinical practice limitations. All attendees will be muted except the presenters. Time at the end of the presentation will be reserved for questions. Please type a question in the question chat window at any time. We will read as many selected questions as possible to the presenters during the allotted question and answer time. A recording of this webinar will be archived on the ASRM website in the coming weeks. Please watch your email for notification. Let me introduce our moderator, Sean Tipton. Mr. Tipton is Chief Advocacy Policy and Development Officer at the American Society for Reproductive Medicine. Over to you, Sean.
Thank you, Sarah. Good morning, everyone, or good afternoon or good evening, depending on where you are on our globe for this historic occasion. I don't believe we've ever had a webinar with the leaders of these three most prominent organizations in the space of reproductive medicine. What we're going to do today is discuss the broad topics of the leadership provided by ASRM, ESHRE, and IFFS, and we will hear from each of the leaders of those organizations in turn. So we will hear first from Catherine Rakowski, the president of ASRM, then from Christina Magley, the chair of ESHRE, and then from Linda Judice, the president of IFFS. So let me first introduce Dr. Catherine Rakowski, who's director of the ART laboratory at Brigham and Women's Hospital in Boston and professor of OBGYN at Harvard Medical School. Dr. Rakowski serves as the president of the American Society for Reproductive Medicine. She's authored over 150 peer-reviewed papers on various aspects of mammalian egg and embryo physiology, published numerous news releases and abstracts and book chapters, and has co-edited 7 books. Dr. Rakowski.
So thank you, Sean, very much for that kind introduction. Before I start discussing my PowerPoint presentation, I'd like very much to thank my colleagues, Christina Magley and Linda Judice, on behalf of the ASRM, for coming together to put this joint statement out in this very serious time of the COVID-19 pandemic. So we'll be discussing 3 broad topics in this hour. We'll be discussing declaration of the principle behind the joint statement and defining the problem, and I will be addressing this section of our statement. This middle statement, reproductive medicine is essential, will be addressed by Christina Magley. And then finally, the third section in our statement, research needed, will be discussed by Linda Judice. So as for declaration of the principle behind the joint statement and defining the problem. So why did we put out this joint statement? Well, we thought as 3 of the leading societies of reproductive medicine that we should come together with one voice to reaffirm the importance of reproductive care when parameters of the COVID-19 pandemic began to be delineated. This unified effort was achieved by 2 writers from each of the 3 societies. So Eve Feinberg and Alan Penzias wrote from the ASRM perspective, Luca Gianiroli and Anna Vega from ESHRE, and Marcus Horton and Steve Ori from the IFFS. So as we all know with respect to the principle behind this document, reproduction is really an essential human right. I think we would all agree to that. In addition to that, I think we would also agree that reproduction really transcends race, gender, sexual orientation, or country. And so this pandemic is literally reaching each and every one of us, regardless of our position, ethnicity, and sexual orientation or gender in society. So as we know, infertility is a disease. Infertility was defined as a disease by the WHO now several years ago. And unfortunately, also as we know, it generally is not curable, but is most often treatable. It is a very serious disease in that it affects 8 to 12% of couples of reproductive age and increases with maternal age. You can see on the right-hand side of the slide here, the red line showing how the likelihood of infertility increases with maternal age, and particularly so after the age of 39. With the uncertainties of the SARS-CoV-2 pandemic and potential delay in treatment, patient concerns for timely treatment for their infertility were understandably very much heightened. And this principle was held very close to the hearts and minds of all three societies as we put together our documents. So with respect to defining the problem, suffice it to say that and as we all know, this ghastly disease began in Wuhan in the Hubei province in China. And within very short order, it spread throughout China. This map shows you on January the 23rd, 2020. You can see how the severity of the disease increased over time, spread to additional countries. And of course, Italy was very severely impacted in Europe. By March the 2nd. And again, you can see by April the 1st how it spread even further, by May the 1st even further and to a greater degree. And then finally, with the last map that I could find on May the 31st, you can see very clearly how this is definitely a very, very serious situation for the world. And indeed, the WHO declared this as a pandemic on March the 11th, 2020. So it was in relatively short order after the WHO declared this as a pandemic that each one of our three societies started to put out guidance documents as to how practitioners and professionals in our field should manage their practices and care of their patients. So the ASRM put out a document. This was our initial document, which was put out on March the 17th. ESHRE put out theirs on March the 19th. And IFFS put out theirs on March the 12th. So as you can see, all three societies actually released their first document within a week after the WHO had declared the coronavirus as a pandemic. And the unifying theme in all three of these initial documents was to suspend new treatment cycles except for the most urgent cases. There were other pieces of information that were added and were perhaps somewhat unique to each one of these three documents, but that was very clearly a unifying theme across all three of the documents put out by the three societies. Well, since that time, we've also, and each one of us have done this, continued to put out documents because this is very much a changing landscape, and it was important to keep up with the situation as it evolves, so that we can provide the best possible guidance to our patients in a timely fashion. So the underpinning of our recommendations were really fourfold. First of all, to guard the health and safety of our patients and staff. Secondly, to help conserve critically needed healthcare resources. Thirdly, to recognize our social and community responsibilities. And then altogether, combining these three, hopefully then to contribute to so-called flattening the transmission curve. In each one of our three initial documents, we also stated the importance of adherence to local and national governmental rulings and how this might impact a particular clinic in a particular locale. So as I mentioned, since our initial documents, we've each put out subsequent releases. So for the ASRM, we've now released 5 updates. The most recent update came out on June the 8th. The first of these updates basically clarified terms, particularly infertility and what were essential services in reproductive medicine. The second update reaffirmed the initial recommendations. The third update is the most extensive of those that we put out, and really provided guidance on when to resume care, how to assess the risk that would be involved in assuming care, and then thirdly, how to mitigate those risks as identified in the work for assessing the risks that would be involved in resuming care. In the fourth update, we focused on testing, the potential effects and influences of the COVID-19 virus on pregnancy outcomes, and we also addressed third-party reproductive issues. In the fifth update, which, as I mentioned, just came out last week, we reiterated some of the issues regarding third-party reproduction. We also discussed fertility services to healthcare workers, and we addressed travel restrictions, which are really very important, both for patients as well as for staff. And finally, we addressed resumption of reproductive surgery in the setting of the pandemic. We all recognized, I think, that it became quite clear early on that we were going to have to resume care and infertility services in the setting of the pandemic. And as I mentioned, we're all trying very hard to continue to provide updates in a timely fashion to inform our members. So ESHRE has done likewise. This was their initial document, which, as I mentioned, came out on March the 19th. And they since have released 3 subsequent updates, the most recent of which is the extensive document, really providing guidance on recommencing ART treatments. And then finally, with respect to the IFFS response, this, as I mentioned, they were the first to put out an initial document on March the 12th, and they since have released 2 documents, the most recent of which was on May the 6th, again, outlining and highlighting specific areas that they felt were particularly important to their members in their society. So with the passage of time, it's become clear that we really do need to develop mitigation strategies, and with the emergence of additional data that have occurred, we have independently, as the 3 societies, reaffirmed the importance of continued reproductive care during this coronavirus pandemic. I say that we've done this independently, but also with respect to the joint statement that we're discussing today, we've come together with a unified voice and really reaffirmed the importance of this. In this joint statement, we've also sanctioned the gradual and judicious resumption for reproductive care. We highlighted the safety that is absolutely of paramount importance, the use of telehealth when at all possible, and the value and the benefits of using telehealth in this risky environment. And then finally, we also have highlighted the importance of providing mental health support, not just for patients, but also for staff during these very uncertain times. Of course, we've also reiterated the importance, the essential importance of reproductive medicine to humankind. And as I mentioned at the beginning of this short discussion of mine, this is the middle section of our joint statement, and this will be discussed by Christina Magley. So thank you so much for your attention, and I'd be delighted to answer questions during the question and answer session.
Great. Thank you so much, Dr. Rakowski. And Dr. Rakowski will be available for questions at the end, as all 3 will take questions together. Our next speaker is Ms. Christina Magley. She's an embryologist who's coordinated the laboratories at the Italian Society for the Study of Reproductive Medicine in Bologna since 1995. She has served in a number of positions within ESHRE, where she's coordinated the special interest group in embryology, been a member of the executive committee, chair of the special interest groups, and is currently the chair of ESHRE. She received a degree in biological science from Bologna University and a master's degree in immunology from the Venezuelan Center for Scientific Research in Caracas. Ms. Magley.
Yes, hello. Good morning, afternoon, evening to everybody, and thank you for attending this webinar. I join Catherine in acknowledging the importance of the 3 societies having drafted this document as an only voice to assist reproductive medicine professionals in performing reproductive care nowadays. We now move then to the second part of the document, whose title is Reproductive Medicine is Essential. We started from the consideration that reproductive care is essential for the well-being of the society, as confirmed by WHO, who defined infertility as a global public health issue. The decline in birth rate is a new reality that we are experiencing nowadays, representing an additional factor underlying the importance of reproductive care to sustain conceptions. And you see here some data reporting about the declining birth rates in the US, where birth rate has fallen to the lowest in 35 years. And in Europe, the number of children per woman was 2.5 in the 60s and is now lower than 1.6. That is a figure that is very far below the 2.1 birth per woman considered necessary to maintain a stable population in the long term. Therefore, considering the contribution of reproductive medicine to deliveries and believing in the need to go for assumption of full reproductive care, we agreed, the three societies, on 10 tasks directed to reproductive medicine professionals to perform ART treatments by making health and safety of our patients and staff mainstream. 10 tasks. So we will see them one after one. The first states that we need to advocate for the well-being of patients. In the current situation where the pandemic is not yet over, we need to act in a system that minimizes the risk of infection and provides the highest security guarantee of physical well-being, in consideration of the psychological aspects that motivate couples to search for a pregnancy through IVF without any further delay. Safety is a must, and always was a must in our field, but now more than ever. Question and task number 2. These are the most recent figures from Italy and Belgium. You know that everything in Europe started in Italy, where the outburst was really aggressive and very fast. And the consistent decline that we observe nowadays, these figures refer to 2 days ago, to the 14th of June. So the consistent decline in the number of positive cases that are represented by the yellow curve that you see on your left-hand side, and also the numbers of the most severe cases requiring hospitalizations and intensive care, that is in the green bars. Well, this situation justifies a control assumption of treatment in our field, at least in Europe. Third task, we need to be proactive in implementing risk assessment before restarting services. Risk assessment means to define the situations at risk and the measures to undertake to keep this risk under control. At this respect, we underline the importance of defining and strictly following a code of conduct, both for staff and patients. As you see listed here, the recommended points are very simple and logical in the current situation. That means washing hands repeatedly, wearing masks, avoid crowded places. But we consider that systematic application of these different points during the 24 hours of our life nowadays represent the constant awareness that if we protect ourselves, we also protect the others. So it means that we have a duty toward the others, and the others have a duty towards us. It is only through collaboration and trust that a safe continuation or restart of activities can be achieved. Task number 4, prioritization of patients can be the case, can happen, can be necessary in some realities for the allocation of limited resources, and for this reason, we consider this best handled at the local level in consultation with patients after carefully assessing local and regional conditions. Of course, some consideration could include some medical factors, like the impact that the delay on treatment can have on patient prognosis, such as ovarian reserve or endometriosis, and other considerations, of course, that can be applied in the different situations. Task number 5. It is about counseling patients. Patient must be informed of the current situation. We do now, as we always said, our best to minimize the risk of infection, but the virus is still around. We didn't get rid of it yet. We do not know much about the possible effects of infection during the initial stages of pregnancies, and for this reason, recommendations must be given to our patients on how to behave during treatment, even before treatment, when they are planning treatment, but during treatment for sure, and especially after embryo transfer, and even more if they get pregnant after the embryo transfer. Of course, alternatively, we can plan to patients the possibility of postpone treatment to times in which maybe the situation is better than now. Task number 6, we have to adhere to active risk mitigation strategies to reduce the risk of viral transmission. This is via adaptation of services using personal protective equipment, using social distancing, cleaning and repeated disinfections. We heard these points so many times during these months, but certainly it's the winning strategy to overcome this situation. And we also have proposed a triage plus testing system that is aimed at organizing a COVID-free clinic for which patients and also the staff are systematically asked to fill in a triage questionnaire at specific time intervals and to be tested before being admitted. Task number 7, we recommend to develop clear and codified plans to be able to provide care while maximizing the safety of our patient and of the staff. Therefore, we needed to have specific COVID-19 SOPs that detail the adopted strategies. Task number 8, remain informed and stay current regarding new medical findings. You very well know that this is a very fast evolving field. Information is coming day after day. You know that in many cases it is case reports. We have also seen some issues that have been retracted afterwards. So it's not easy to manage this amount of information that we receive. Nevertheless, our 3 societies dedicated in the respective web pages a section dedicated to the new information coming in, scientific information coming in, and this can be of help for all professionals. Task 9, develop or refine robust emergency plans. We are suggesting to organize the staff in mini teams, small teams that are doing the same task but are independent one from the other, and also, if possible, to arrange agreements, emergency agreement between different ART centers. In this way, we can guarantee continuity of treatment provision, even in the case that one member of the staff is unfortunately infected by the virus. Task number 10 is be prepared to interrupt medical treatment if needed. In the case of IVF patients who test positive during the treatment, reproductive medicine, the professionals that are in charge will consider the opportunity of canceling the cycle, depending on which point the positivity came out, which type of patient we are dealing with. But certainly, one thing is sure, embryo transfer will be delayed until the patient is SARS-CoV-2 negative. For what we said before, we do not know which are the consequences of an infection during the initial phases of a pregnancy. There is also a scheme that is in the upper part of the slide, in which there is a sort of flow chart in which we propose a systematic triage and testing that will make this situation less likely to occur, because we test patients, we track patients, and we admit patients only if they test negative. So my final slide is summarizing the 10 points that we just presented, and they, as we said, represent the consensus from ASRM, ESHRE and IFFS for a gradual and judicious resumption of full reproductive care during and hopefully after the pandemic. Thank you.
Thank you very much. And our next speaker is Dr. Linda Giudice, who's the Distinguished Professor of Obstetrics, Gynecology, and Reproductive Sciences at the University of California, San Francisco. She's a biochemist and reproductive endocrinologist specializing in endometriosis and infertility. She's mentored more than 300 students, fellows, and faculty, authored more than 350 peer-reviewed publications, served as co-editor of 7 textbooks on women's health, reproductive and environmental health, endocrinology, endometrium, and endometriosis. She is currently president of IFFS, and I'm proud to say a past president of the ASRM. Dr. Giudice.
Thank you very much. Our joint statement also addressed research, and the question is, how can reproductive medicine practices further COVID-19 research? Well, they are uniquely positioned to gather data. Reproductive medicine professionals and practices are essential frontline resources for screening, monitoring, assessing prevalence, and assessing impact of COVID-19 on patients and their progeny through point-of-care data. ESHRE, ASRM, and IFFS are committed to continuous monitoring of effects of COVID-19 on gametes and reproductive tissues. Also to collecting data on pregnant patients infected during the pandemic and assessing outcomes of mothers and neonates. Examples of research and registry efforts and the need for standardized data collection are shown in the next few slides. SART, the affiliate society of ASRM, for example, is including mandatory COVID-19 related questions in their clinical outcome reporting system registry of assisted reproductive technologies, which accounts for nearly 90% of all the ART cycles in the US. Shown here are 2 fields that demonstrate entries that participants can fill in. On the left is canceled egg retrieval and cycle complication input screen with a field for cancellation for COVID-19 related issues. And on the right is a field for canceled embryo transfer. I should mention that other registries and databases are doing similar things, such as the African Network and Registry for ART, ANARA, and also the Latin American ART Registry. ESHRE is gathering global case-by-case reporting on the outcome of medically assisted reproduction, or MAR, conceived pregnancies in women with confirmed infection, and is gathering data and mapping MAR-ART activity during the pandemic, country by country, and or when they stopped offering treatment and when they have resumed care. So as of April 18, 2020 on the left, the orange shows countries where centers were not performing ART, and then the most recent data from the ESHRE working group shows that the majority of centers, now shown in yellow, ART treatments have restarted. IFFS is conducting periodic surveys through the IFFS surveillance, which is a triennial reporting of data on ART practices focused on standards, policies, and laws, published in our journal, Global Reproductive Health. Between April 21st and May 8th, we initiated a surveillance survey to assess the status of infertility services in each of the responding countries. You can see here during that time period that the blue indicates closed or limited access for special circumstances, which was the majority of practices that responded, and green was open with no restrictions, and yellow showed different circumstances for private and public centers. The major take-home of this survey, which is currently being written and being submitted for review, peer review, is that the majority of centers did not feel that infertility was an essential service at the time. And they were asked why they had closed, and about equally divided were government mandates, professional society recommendations, and voluntary. In addition, staff safety was assessed, with about 20% of responding countries saying that staff infections had been detected. There are many research and registries on pregnancy and neonatal outcomes that have emerged just over the last 2 to 3 months. Shown first here is ASPIRE, which is a nationwide prospective cohort study of pregnant women and their offspring conceived spontaneously or with ART during the pandemic, and this comes from my own institution, UCSF, as does the Priority study, which is a pregnancy registry nationwide of pregnant women confirmed or suspected of COVID-19 and how COVID-19 impacts pregnancy and neonates. In addition, the U.S. National Institute of Health Maternal Fetal Medicine Unit has an outcomes study, which will sample 21,000 medical records in a retrospective cohort study about pregnancy complications, neonatal outcomes, and the postpartum period. Mother to Baby is an observational prospective registry in the US and Canada, and also has a lactational survey in women participating. The pediatricians in the US have launched the National Registry for Surveillance and Epidemiology of Perinatal COVID-19 Infections and have a registry of maternal and neonatal data. And the International Society for Thrombosis and Hemostasis has the COVE-PREG-COAG study, which is a prospective international registry to determine the incidence of coagulopathy and thromboembolism and treatment and prophylaxis on outcomes. RASCOG, the Royal Australian and New Zealand OBGYN Society, has begun a national registry for Australian women, and also the Cochrane Group, the Cochrane Gynecology and Fertility Group, has a website and a registry for pregnancy and neonatal outcomes. FIGO is launching a registry of registries on COVID-19 in pregnancy and the postnatal period, encouraging standardized data collection to determine SARS-CoV-2 natural history, prognostic factors, interventions affecting outcomes. And the UK has the PAN-COVID study, where the main endpoints are miscarriage, growth restriction, stillbirth, preterm birth, and vertical transmission. In addition, the International COVI-PREG is a prospective data collection for future research on SARS-CoV-2 infection in pregnancy, and the collection and the establishment of a data collection system through healthcare facilities networks to assess risks linked not only to COVID-19, but also for other emerging pathogens, and this is out of Switzerland. The Institute for Tropical Medicine in Belgium has a survey conducted in 13 languages. FOGSI, which is the OBGYN Federation in India, also has a national registry on COVID-19 infection in pregnancy. And the Pan American Health Organization, working with the World Health Organization, has a health surveillance database of COVID-19 and pregnancy data and a reporting system in Spanish, English, and Portuguese. And the WHO has a global platform through the REDCap database for reporting and depositing data. So you can see that there are many registries and studies that have been launched. I think one of the challenges will be to have standardization of data quality, and harmonization. And I'd like to speak on behalf of all of us and give some final thoughts. that reproductive care is essential and reproductive medicine professionals are in a unique position to promote health and well-being. ASRM, ESHRE, and IFFS are collaborating to advocate for patients and to gather data and resources to enhance the understanding of COVID-19 as it pertains to reproduction, pregnancy, and the impact on the mother, fetus, and neonate. We welcome collaborations with other organizations and societies to achieve our common goals, and also in data catchment and impacts on reproductive health and health care. And we believe that lessons learned from these experiences will be useful as humanity deals with the inevitable future pandemics. Thank you very much.
Thank you very much. So now we will move on to the question and answer period. We will now open up the floor to questions for our panelists. Mr. Tipton will be moderating this session.
Great. Thank you so much for those outstanding presentations, all three of you. So let's get into the questions. And we've got an early one that's a little bit on the technical side, and it's directed about the ESHRE guidelines. And that the question is, why is ESHRE advising antibody testing rather than SARS-CoV-2 testing? Ms. Maggie, would you like to take a shot at that?
Yeah, this is a very common question. I heard this question several times. I think that the decision to advise for antibody testing goes as a complementary part to the triage approach that we proposed. I didn't go into details, but they are available, of course, in the document release. We perform a triage 2 weeks before start of treatment. Triage is made of several questions, specific questions that both patients and staff have to fill in. We repeat the triage at the beginning of treatment for patients, and then we combine the test, the serological test. This is especially useful, as I said, in combination with the triage. It permits us to detect cases that at the infection time before, and of course, it's not that we exclude a PCR testing that is certainly recommended in cases of doubtful results or to have confirmation of the result obtained.
Great, thank you so much. Either do you want to comment on that, or are we okay?
I'm fine.
Okay.
I'm fine, thank you.
So the second question I'm going to direct first to Dr. Giudice, and that is, could you speak a little bit to the challenges of coming up with, since in your case they're the broadest, the global recommendations, understanding the different conditions that the virus is presenting to people in different specific places, and the specific requirements that their local governments may be imposing as well?
Sure. There's also the issue of timing and prevalence of disease. We see that in different parts of the world now, there's an uptick in the number of new cases, especially in Africa and in Latin America. And other parts of the world have essentially been through the first wave and are concerned about a second wave. And so the ability to have guidances is very much going to depend on the local situation and monitoring the R factor, if you will, and the number of new cases, the number of deaths, because those will surely guide governmental input and regulations. In addition, I think local and regional health professional organizations will have a major role in assessing the situation and being able to provide guidance to their constituents.
Great, thank you so much. Anybody else?
So Linda, I did actually have a question for you regarding data collection and whether there in these registries there's accommodation to collect information on reoccurrence of infection. Because there is some discussion that people that are originally infected can be infected again. And I was just wondering whether pathways of infection might be different and the endpoints might be different of the infection itself under those circumstances.
That's a great question. I'm not sure there's such a fine degree of granularity in the questionnaires about recurrence. However, in the databases, if there is a particular group that has a pregnancy and then perhaps a year from now has another pregnancy and perhaps a recurrence, with the appropriate monitoring and antibody testing or vaccination, I think we will be gathering more and more data over time.
Yeah, terrific. Thank you.
Dr.
Maybe
Kathy,
a little bit too early. Sorry, it's a little bit too early to have to estimate reinfection, at least in our latitudes, because we are seeing what is happening in China now. So, but certainly it's something that we have to keep track of, for sure.
Right.
Dr. Cassie, let's send this one to you, and that is, can you talk about how with the ASRM group you tapped into the expertise of infectious disease specialists and epidemiologists? I mean, did they play a role in development, and what was that role and how did it work?
Yeah, thank you. Excellent question. So the original task force that we convened, I believe it comprised 17 members, and one of the members of the original task force was indeed an infectious disease specialist. And she very much weighed in to all the discussions as we developed the initial guidance document. And I will stress that it was a guidance document. These are recommendations. These are not guidelines. They did not go through the normal process of our documents if they're going to become guidelines to members. Since very shortly thereafter convening the first 17 members of the task force, we also brought in an epidemiologist from the NIH, who is an expert epidemiologist who has played an integral role in forming of the subsequent updates. Overall, the task force works extremely coherently and cohesively together. We have at least one, if not more, meetings now before the next update is released, where we put our heads together and think about what next topic is important for our members to consider as the reproductive care is really getting ramped up again and is resuming.
We've gotten a number of questions kind of getting into some of the specifics of the testing piece. So one of them is, when the local situation in terms of prevalence or transmission curve, when do you think you would need to stop new treatment for or prioritize again who's getting the treatment? So the question is kind of what will the conditions look like to trigger a second kind of slowdown or signaling to people that they should not initiate new treatments?
Well, I'll take a stab at that. Just from the experience and the reading and the education that I've had so far in epidemiological aspects of disease transmission, it seems to me that the benchmark in most places is all about the capacity of hospitalization of people when infected. And I believe that the hospitalization capacity varies according to the locale. But certainly from the United States point of view, that would be one of the benchmarks that we'd look at very carefully. I don't know, Christina or Linda, do you want to weigh in at all?
Yeah, intensive care units availability, this is another point. And of course, the speed of the outburst, of the increase of cases, because at least what happened in Italy, that we had a tremendously fast increased number of infected people, and we felt in a situation in which we couldn't cope with the number of patients requiring ICU compared to the number of available places. This was an extraordinary situation. I think that probably every country should have faced the same situation. We see what is happening in the UK. They are still struggling with such an increase in numbers. So yeah, this is another point important to keep under control.
I would agree with those comments. I think it's also important as we think about prevention, and that the WHO recommendations with regard to social distancing and also for using masks and sanitation, are so critical that hopefully we can prevent these recrudescences of local increases.
Great, thank you. And we don't really have a urologist or andrologist on the panel, but so Christine, I'm sending this question to you, and that is the question
I'm
is
an
about.
andrologist. I'm an andrologist. Come on.
The question really is about testing asymptomatic men, and what the latest research is showing, and where we think the research is heading in terms of the risk of transmission through sperm.
Well, I would say that there are conflicting reports on that. There are some reports in which I remember a figure of 30, almost 40, 38, I think, positive men were tested, and in 6 of them, the virus was found, the RNA of the virus was found in the seminal fluid. However, there is a case report that states completely the opposite. So we know that there is that possibility. We know that spermatogonia, Leydig cell, and Sertoli cells are the receptor used by the virus to penetrate the cells. So potentially we are at risk, potentially. However, there is no convincing evidence, and beside that, I have to say that in the lab we all work with such strict control measures and protocols. We do so many repeated washings that I'm really convinced. Maybe there will be an evidence coming soon that say that I'm wrong, but I'm really convinced at this moment in which we are not exposed to an increased risk. We normally treat hepatitis positive men, and we follow the same criteria. And I would say that this can be managed. It's just a matter of awareness and know.
Excellent, thank you.
I'd like to make a comment, and Christina mentioned finding the virus in semen. Finding the virus doesn't necessarily mean that the whole virus is there. It could be fragments. This has been shown also in breast milk, for instance. And this is a real opportunity for us as a community to gather data, because this is such a critical issue with regard to COVID-19 and male reproduction.
And I would just add to Christina's comments that, of course, every lab should be performing universal precautions anyway, and it is particularly important to do so in this setting. I think most programs are probably not testing the men, so the safe assumption is that they are positive. That's how I'm running my team. Assume they're positive, but do everything you can to mitigate against the virus being in the final preparation by, as you say, doing multiple washes and adopting universal precautions.
Great, very helpful, thank you. This question's, I don't think any of the groups really have concrete recommendations, so it's really going to be a little bit of personal opinion, but that is, how should we be talking to the broader community about infertility at this point? And that is, these guidelines are geared very much to people actively seeking infertility care. And do you think there's a concern that people are going to be afraid to seek that care, even to start the process in the wake of COVID? And is there some way we can address that? We'll let Linda start this one.
Okay. I think that's a very reasonable concern. The data so far with regard to pregnancy are reassuring, but we do not have really good data, especially in early pregnancy. And also we know that the effects during pregnancy of this virus do not seem to be as draconian as the effects of COVID, the SARS virus and MERS, and also in the pandemic of 1918, where maternal mortality was very high and other pregnancy complications. So I think it's also important that we look at what's happening now in the non-pregnant population, and now more increasing data in the pregnant population with regard to those who have comorbidities. So if someone has comorbidities, that will raise a much greater concern for pursuing fertility care and getting pregnant compared to someone who does not have those. So this is really not a one-size-fits-all. It's very individualized, and I think that patients should be encouraged to have these conversations with their healthcare professionals because it is an individual or couple decision.
And just to add to that, those comments, Linda, which of course I completely agree with, my understanding from the current literature is that the virus does not cross the placenta. Correct me if I'm wrong. I believe there are a couple of reports that have shown that placenta does have virus in it, but the question is whether that was introduced at the time of delivery as opposed to it actually being present when the fetus was in utero. So that, I think, is another perhaps important point to make for patients, people, when they're thinking about whether to conceive in this setting or not.
There is an additional point that is really not very pertinent, but is on the margin of the situation. That is the economical consequences of the pandemic. So I think that people now is struggling to put together the money that is needed to undergo a treatment cycle. For those cycles that are performed in public services, of course, now the restart is very gradual because in public service is practically, well, free of charge or very small charge. The restart is very, very slow. So I'm afraid that the waiting list will become bigger and bigger. While for private centers, it's a matter of money issues. So yeah, I think we are really confronting a difficult time in this respect.
I think that's a good point. And actually, let me follow up on that a little bit, and that is, let's talk about the reaction of patients as the pandemic took hold, and as your groups issued these recommendations, and as we are coming into a different side of it. I wonder if you all could share your experiences of communicating with patients and the reaction and taking their perspective into account. Because I know your answer, Dr. Rakowski, I'm going to let you start with it.
Well, thank you. I don't know if you do know my answer, but
well, at least I was witness to some of those interactions. Let's put it that way.
So, I mean, certainly there, and very understandably, there were a section of the infertility patient population that was very upset when we put out the guidance that we recommended that new treatment cycles should not begin. And as I think it's become very clear to everybody, we made these recommendations based upon the uncertainties. No one knew how this virus was going to unfold. We were in a dire situation with respect to PPE and resources at the time that we put out the initial document. So very understandably, there were a section of patients that were really concerned and I think in some respects very upset by the guidance that we put out. I think largely that degree of being upset was driven by the uncertainty as to how long the pandemic was going to persist and how things were going to evolve with respect to care of patients, people that were infected. So in short order, as things settled down and we really started to see with the passage of time what the landscape looked like, we made the recommendation that there should be judicious resumption of care. But we heard loud and clear the voices of patients who were upset, and we really tried to address that. And by the way, we didn't put out the first guidance document without recognizing that this was going to be a very sensitive issue and of great concern to many people. It's obviously, people who have infertility are stressed anyway. They want to get on with their treatment and hopefully establish a pregnancy as quickly as possible. So it was all extremely understandable. But I hope very much now, looking back on how the ASRM, and I'm speaking now from the ASRM point of view, how the ASRM put out the documents, the thought that was put into the documents, I hope they appreciate that this was done in no malicious way whatsoever, but really to try to keep everybody safe and also do what we felt was right from a society point of view. Thank you.
Yeah, we had the same experience. We also had very, very negative and aggressive reactions, especially at the beginning when we started recommending treatment cancellation for all patients, not only the ones that were at risk or the positive ones. At the beginning, it was, I think, a little bit difficult to handle that. Okay, I think that little by little they started to understand. Also, those that were claiming that we were breaking human rights, they started to understand that this was done even against our own interests, because we all want to work, we all want to have good results, we all want to collect data, I mean, to make patients happy. So this is our intention, our aim. But then now we came to a point in which I always hear from our medical doctors that if they spend something like maybe half an hour to talk to patients before, to go through consent forms, and information, but you certainly, Linda, know better than me. Now the time needed is double, because you have to go to all the explanation, alternatives, risks, recommendations, and so on.
I agree with both previous comments. I think it's a natural reaction to have disappointment. And also at the beginning of the pandemic, there was perhaps a global, really lack of recognition of how serious this disease is. In our constituency through IFFS, I don't think we have really sufficient data about patient reactions, but we do know that look at China, for instance, where it was very clear from the beginning everything was going to stop, and that was the epicenter, and I don't think there was really much of a choice, but how they have gotten back into having cycles now is, I think, quite admirable. They're exercising all the precautions, et cetera, but my sense is we do not just in China, but across the globe, have a really good survey of patient reactions and feelings about this, which I think we probably need to begin to collect more.
I think there is one survey, I believe, that was done by Resolve, showing that about 30% of patients felt they should cease treatment, 30% wanted to continue, and the remainder were sort of ambivalent one way or the other. I will add just one other note with respect to the reaction of patients. We actually have on our task force 2 patient representatives. And these patients they were in treatment or about to go in treatment or having had treatment, and were able to give some very interesting sort of personal perspectives as well as we wrote the guidance documents. And they're still members of our task force. We value their opinions immensely.
Yeah.
So we got a.
I'm saying that we also have a patient representative, because we mainly talk to professionals as a scientific society, but we thought that the patient representative was more entitled to have a direct and continuous dialogue with patients. So this is the way a little bit we divided our duties in the working group for the COVID-19 activities.
We've gotten a follow-up question on some of the sperm testing, and that is there a concern that COVID can be transmitted sexually? not in the infertility link, but should it be considered a potential sexually transmitted infection? Do you have any thoughts on that?
We are not andrologists, but I would exclude at the moment this possibility. As far as we know, as Linda was saying, I mean, finding the RNA in the semen doesn't mean that the virus is active over there. So we don't know yet, but we do not have any evidence. So if this is true, now we have to stop all sexual intercourse. So we are going now out of our field of reproductive medicine, because we can do something to the semen. We can remove the plasma. We can use gradient. I mean, we can perfect the situation, but this would mean a message to the other parts of the community that is not resorting to IVF. So no, at the moment, I don't think there is any evidence whatsoever.
And actually, I would think that just, during having intercourse, actually, if one of the parties is infected, is going to pose a much greater risk than actually the infection being transmitted via the semen or through the reproductive tract.
Great. Any parting comments? I think we're about out of time, but let me just ask you this, and that is I know you have all issued multiple statements. What do you anticipate that continuing? And we'll just start with Dr. Rakowski and then go through.
So thank you, Sean. So the initial updates were released every 2 weeks, as you know. The most recent update which is update number 5, was released on June the 8th, which was a month after update number 4. And we have said in update number 5 that we already release update number 6 within a month. It depends. It depends what happens. We may actually have to stop care again, God forbid, or with a second wave, in which case it may well be that we have to continue with these updates on a regular basis. As things stand, the plan is to continue on a monthly basis from the ASRM point of view, but we'll just have to see how it goes. We're already in the middle of June. And Dr. Fauci is concerned that the second wave in this country is going to occur September, October time, which is just a matter of months away. So we'll just have to see how it goes. Thank you. And I will just, if I may, just make one other comment, just again, to my dear colleagues who are on the panel. And Sean, thank you very much for doing such a fabulous job moderating. But to Linda and to Christina, this has been such a pleasure working with you both and participating in this joint effort. As I've said so frequently, we're so much stronger together than we are separately. And I really hope that this is the beginning of a much closer cooperation among our 3 societies. So thank you so much.
Yeah, it is said in a very, very nice way what was going through my head. Of course, you dominate the language much better than me. So very well said. I would just add that I would really like that our example of being different groups, but having elaborated the need of staying together because we need to provide help, even if situations are very different, because you are experiencing something that's completely different in the States to what is now in Europe. But nevertheless, we could find an agreement. And I would really like that this example of ours, that I hope to be repeated more frequently in the future, even for less severe situations, would be followed by our politicians, generally speaking. I mean, there is no person at the government and at the opposition, I mean, in front of these catastrophes or this terrible situation, let's join effort together to find a solution, irrespective of who is, one color compared to the other, politically speaking. I mean.
Thank you very much. Dr. Giudice will give you the last word.
Okay, thank you. So IFFS periodically will be issuing statements. We also will be following up on the survey that we launched to see how things have changed, and over the next 6, 8, 12, 18 months, things may change quite a bit from time to time, depending on the course of the virus. I think Christina's comment about politicians is very important. I think that ministers of health would be well served to understand the issues and the importance of reproductive care as an essential service. And so educating that way, I think we can work closely together as organizations and have a bigger impact on a global level. So collaboration is key, and I also want to thank ASRM and ESHRE for the opportunity to work together and to be part of this webinar. Thank you.
Thank you all very much, and I believe Sarah has some parting instructions and comments for us.
Absolutely. Thank you to our panelists, to our excellent moderator, and to the attendees. Thank you for joining us. You will receive a survey by email after the session. Your feedback helps us give you the most relevant content, and your input is appreciated. This session was recorded and will be available on our website in the near future. Please join us for our next webinar scheduled for Thursday, June the 18th on the new normal, resuming fertility care in the COVID world. For any further questions or comments, please don't hesitate to contact us at webinars@asrm.org. This concludes the webinar.